There we are. We are live, everyone. Thank you so much for your patience. It was just taking a few moments for this session to start. Thank you so much to everyone who is registered, who is joining this evening. My name is Sandy. I am a clinical embryologist and fertility coach and patient advocate. I will be your host tonight as we talk about PGT A testing in the IVF lab. I've got two experts with me here this evening, so pleased to have you both, and would love to do some introductions and also just a bit of general housekeeping for everyone who is joining us this evening. Please use the Q&A box to submit your questions, and that is the opportunity to ask these questions anonymously. The session is being recorded, but your name will not be recorded, so to say. And if you do need to dash off before we have finished, then this will also be available on the My IVF Answers website. I think probably from tomorrow, once that recording has been uploaded. And on to our experts tonight. Thank you both. So we've got Carolina from Clínica Tambre joining us this evening. Please, would you mind introducing yourself to our audience tonight?
Sure. Thank you, Sandy, for the introduction. Yeah, I'm a senior embryologist at Clínica Tambre, which is based in Madrid. I've been working over 7 years at the clinic, and well, I'm thrilled to be here to answer all the questions that might appear.
Brilliant. Thank you so much. And Kirsha, you are dialing in from work from NewLife IVF in Greece. And please introduce yourself for us tonight as well.
As you said, thank you for having us tonight. My name is Chrysa Karakosta. I'm from NewLife IVF Greece, that's located in Thessaloniki, northern Greece. I am a clinical embryologist, but I'll be honest with you, for the last nearly 9-10 years, I now head what's called the international team at NewLife. I still go in the lab, but my main focus is sort of dealing with international patients.
Wonderful. Thank you both for being here tonight. So I think we will just go ahead and talk a little bit briefly about PGT-A in general for our audience tonight. So for those who have joined and not necessarily know what PGT-A is, it is the pre-implantation genetic testing for aneuploidy, and this is where we perform a biopsy on embryos to test them for any chromosome abnormalities. Now, Carolina, at your clinic, would you say that this is something that is performed often on your patients? Do you know roughly how many cycles you do with PGT-A every year?
So it is something that we commonly used because, here in Spain, there's part of the treatments that are covered by the public hospitals. So most of our patients, since I work at a private clinic, have advanced maternal age, which is the main indication for this kind of procedure. So I'm sorry, I can't remember the numbers of exact cycles, but we do it quite often. Most of our cycles are PGT, but because there's a medical indication beside that.
Yeah, of course. And also kind of important to note for the audience and those who have joined us this evening, depending on where you are, PGT-A might be something that is considered a standard protocol or part of your treatment. In some countries, it is what we call a treatment add-on. Where I'm based in the UK, it is a treatment add-on. It's something you have to select and therefore also something you have to pay for. And in some countries, this can be quite expensive and possibly one of those limiting factors in accessing that care. Equally, as we were talking about backstage before we started, when I started my embryology career in Sweden, PGT-A testing was not legal or allowed. That was 16 years ago, and today it is still not allowed. So it's really interesting to see these differences in practice. Yeah. And what about you, Kisha? What is your experience in NewLife?
Of course, it's something that we do offer here at NewLife, but the Greek legislation is very specific as to who is allowed to have PGT-A testing. So in order for us to be able to perform any PGT-A testing, we need to get approval from the Greek National Authority of Assisted Reproduction. This is the UK's HFEA that oversees all clinics and license our clinics. And for patients to be able to be permitted to perform such testing, they need to meet specific criteria. Criteria number 1 being over 40. Criteria number 2, having 3 or more failed treatment cycles. Criteria number 4, having 2 or more miscarriages, or of course having some sort of abnormality in their karyotypes. So they don't have to meet all of these criteria, either or. So as you understand, indeed, it's something we do offer. Again, as Carolina said, we do have a lot of women that are of an older age, or sometimes as international clinics, we do receive patients that have failed many, many times in their own countries and come to Greece or to Spain for hoping to have a better outcome. And hence, yes, we do quite a lot of PGT A testing. The same thing as Carolina. I can't tell you numbers. I don't remember them by heart.
That's okay. That's all right. No, not at all. I think, from working in the clinics, we'd always be mindful of those stats if the biopsies landed on a weekend, because that was something that always made us think a little bit longer. And as embryologists, we're all laughing here. For those of you who are listening in, to do the testing on these embryos, it requires a really delicate biopsy procedure on the embryos. In the UK, we have witnessing procedures, which means that you need someone in the laboratory to witness every step of that process. So moving your embryos from maybe a time-lapse incubator into biopsy dish, and then moving the little cells that you've taken from the embryo into a marked tube, and then freezing the embryo itself. And so that requires a lot of extra staff. And so therefore, in some clinics, that can become a bit more difficult to manage depending on staffing. So those are the times we would definitely know exactly how many PGT A cases we would have if it required extra staff in on weekends. But, no, it's a really interesting thing, because I think there are a lot of guidelines and best practices out there around, to your point, Krisha, if people have had to either have had multiple failed cycles, so recurrent implantation failure, where they say, like, these are things that can be explored in subsequent cycles, or recurrent miscarriages, etc. And then also advanced maternal age. We do find that interesting that they've got kind of 40 years old as one of those. Some other types of literature do suggest that maybe from 37 onwards, it's even something that can be considered. But in general, there are some guidelines that say that PGT A testing might not actually increase your chances of getting pregnant at all. Like our HFEA, that's one of the factors that they say. It is kind of rated red for increasing chances of pregnancy. However, it is rated green for reducing the risk of miscarriage. And that's not necessarily something like you have to read a long way down to get to that point, where you actually find that information that might be related to you and to yourself. So how do you think that, those kind of guidelines either help or hurt people? Carolina, do you have any guidelines in Spain that kind of indicate when these things might be recommended, or is it essentially down to the clinic to help decide what's best to offer the patients?
In Spain, there are recommendations from our main societies, which are the Spanish and the Spanish Fertility Society, and then there's the Biologist of Reproduction Society, and they give recommendations, but there are no strict legislation. So even young patients which have had previous bad experience, maybe several miscarriages, even though their age that would not be within the group, we would do the PGT, and we don't have to go through any specific approval except for PGTMs and so on, that's a different scenario, of course. But we don't have like this in the UK with the traffic lights. Yeah.
I know. It is very different. So that's the HFEA, our regulatory body here in the
Yeah.
UK, the Human Fertilization and Embryology Authority. They license the clinics in the UK and they gather all of the data. So what's really good is that they are your kind of objective source of information. If you want to check out pregnancy rates, you go to them. Fun fact, these have finally been updated as of last week. Previously, they were still showing results from treatments started in 2019. So it has been a long time coming. So we're very pleased that they have this. Also, they do kind of provide best practice recommendations. So they're not set guidelines, but they are around, this is what the literature says, and these are kind of the recommendations. But again, it's not a strict rule. So it is up to patients and their medical doctors to decide what is the kind of best way going forward. And we know very well that it's in everyone's best interest to try to help our patients get a healthy pregnancy as quickly as possible, as less invasive as possible, with as many or as few as minimal kind of add-ons that we possibly can, and in the best way for them. So it is always something that we strive towards. If we talk a little bit about the testing itself, and we kind of talked a little bit on backstage, where obviously we're not geneticists, so there are some cases that can be quite difficult where we always rely on other colleagues as a type of multidisciplinary approach. But there are different types of results that you can get from testing, right? We're taking as few cells from the embryo as possible to minimize any risk to it. We send it off for testing, but sometimes we could get a no result, for example. Krisha, do you want to walk us through a little bit what that means?
Indeed, when we get PGT A results, we can have a euploid embryo. This is a healthy embryo. We can have what's called an aneuploid embryo, which is an abnormal embryo that usually it is not recommended to transfer such an embryo because it will either lead to a failed cycle or a miscarriage or a birth of a baby that may have a problem. A mosaic embryo. A mosaic embryo is an embryo that contains both healthy cells and unhealthy cells. And nowadays, the great thing is that we do have the technology to be able to understand a bit more what sort of mosaic embryo this is. If it's a high mosaic, a low mosaic, and this gives us the opportunity to be able to consult with our cases and with the geneticists and be able to say to them, yep, it's worth transferring. You may not get the same result as if you have a euploid embryo, but they are what we call the second choice embryos following the euploid embryos. And of course, we have what you mentioned, Sandy, the no result embryos, because despite the fact that the embryologists in the lab will do the best that they can to biopsy an embryo safely without damaging it, take the specific number of cells and sort of tube them and send them to the genetics lab, sometimes either because the actual embryo and the DNA of the embryo isn't good enough, unfortunately, the quality isn't good enough to be able to amplify that material to get a result, or sometimes because we don't even meet the criteria of what the genetics lab wants to have as a setting for us to get a result. We get what's called a no result. This means that we either have the choice to transfer it without knowing if this is a healthy, unhealthy, or mosaic embryo, or to rebiopsy it. So put the embryo through the same process. Obviously, this is a very crucial decision that the embryologist needs to consult the patient about, because if an embryo is fragile, we may damage it and we may lose that embryo. So it is something that patients need to understand from the beginning, especially if we're talking about patients that will only have 1-2 embryos, and where we need to sort of weigh the risks versus the benefits of the technique. I don't know if this has covered, Sandy, what you were asking.
Absolutely, yes, absolutely. No, you touched on quite a few important parts there. There are multiple steps along the way that can be considered small risks, but accumulated, they can be a risk to the patient. So it's always really important to take into account everyone's kind of individual circumstances. So we do have a quick question here that has popped in, which is really excellent. Thank you so much. So this is, Carolina, I'm going to go ahead and ask you, can a PGTA result be inconclusive or misleading? Do you have any thoughts on this?
Yeah, so at least following a bit what Chrysa mentioned about no amplification or DNA degraded, those are the two scenarios that we can find ourselves when the results are not conclusive. They see that the chromosome gain or losses are affect a lot of chromosomes. What they see in the amplification is very chaotic. So in those cases, the PGT lab would report that to us, and that's when we should consider rebiopsying if the embryo is suitable for it or not.
Absolutely. To follow on from this, and this is something that's kind of popped up from, there's a clinic in the US that doesn't like PGTA testing, and they, because you know exactly what I'm talking about. So they've almost been pioneering against PGTA testing since it began. But I think what's really important here is to kind of look at the history of this test, because when it started, we were using a method called FISH, right? Where we were looking at maybe 5 to 10 chromosomes. It was very limiting. At the time, we thought it was brilliant science. We thought we could help people. And again, it's all about helping people try to achieve that healthy pregnancy sooner. And, you know, with as little treatment add-ons or like invasive processes as possible. But with fish, it was limiting, and there could have been during that time these false negatives, right, where embryos were reported as being abnormal, but subsequently tested maybe with today's technology, and we realized that actually they were chromosomally normal. This test has evolved a lot since then. We went then through, was it the array, the CGH testing? We're now into like this next generation sequencing. And so yeah, Krisha, what are your thoughts on how this has evolved and how accurate do you feel that the test is today?
It has evolved. The bad thing is I've been through all these stages. But
we've been here a while.
It has evolved and it keeps evolving. I am looking forward to the next stages of PGTA testing, which is going to be the non-invasive testing, which we're not going to have the worry, are we going to damage an embryo, which is the main concern that the embryologist has in the laboratory. But is there misconceptions about PGT? Big time. PGT doesn't mean that if we have a healthy embryo, you will have a definite pregnancy or a live birth. And this is the big misconception. Also, people sometimes hear the high stats that we get following PGTA testing, but what they forget is, first of all, we have to find that embryo to get you pregnant. And unfortunately, when we're discussing about older reproductive ages, finding that healthy embryo means that we need a lot of embryos or a lot of luck. Because unfortunately, as women age, genetic abnormalities increase. This is a fact. We cannot there's no magic lotions, potions, tablets, supplements to change that fact. So I think this is the real important point of when we're speaking to patients and when we're deciding whether we should do it. What we should focus on explaining that PGTA, despite the fact of these advances and how much more accurate it is, our genetics laboratory is giving a 97% accuracy. Still, it's 97, and still, it doesn't correct embryos. It's a diagnosis tool. It tells you things about the embryo, but if the embryo is bad morphologically, or if it is abnormal genetically, there's nothing that PGTA can do to assist us or improve that result.
Absolutely. That's a really great point. Thank you both so much for your answers on this. So yeah, I guess the short answer here, it is possible that it is inconclusive and misleading, I guess, to a point. There are multiple factors that go into the implantation of an embryo, not just the genetic status of it. We need to also be thinking about the uterine environment and hormone levels. There are a lot of other factors. So just because we've got that genetically normal embryo, once we do find it, unfortunately, we're still not at 100% success or implantation rate. So thank you so much for your question. I appreciate that. We do have another one that's just dropped in. So I'll ask you, Carolina, to start. This is not an easy one to answer. And I think that's possibly something that you might have to help explain why it's not easy to answer. But what are the chances of a PGT A tested euploid embryo arresting during thaw for an FET? And this is a day 5 for AB, and can it happen? And do you want to talk about some of the risks that are involved and when this might actually happen in the laboratory?
Yeah, so with embryo arrest, I would imagine that it does not survive to the thawing procedure, right? Yeah, so this is something difficult to predict. What we have, or what we can count is with a very good vitrification system. So even embryo, I mean, obviously, first of all, is to do a very good embryo selection, have a very good embryo of good quality, and that's what's going to help us reduce the risks that the embryo does not survive after the thawing procedure. We can never know 100%, but in the equation, we have to have an embryo of good quality and obviously a good vitrification procedure. That now all the freezing procedures of the vitrification, which is the ultra fast freezing, which is the methodology that's carried out during at this moment, is very efficient. Actually, the survival rates are very high. They're around 98% survival, 95%. So we can say that the chances are high, but we can never assure that we are not gonna have the possibility to lose that embryo, because there may be something within the embryo. With an embryo of day 5 for AB, that's an embryo of great quality, at least if it's Gardner criteria, which is the one we carry out at the clinic, and that's an excellent embryo. So at least from the quality, because we mostly analyze that part when we take into account the survival rate, at least the chances would be that it has higher chances of surviving.
Absolutely. Yeah. Thank you so much. It is, like we discussed before, there are just these small risks along the way. We do everything that we can to minimize any risks to these embryos. They are as precious to us as we are to you. We do care about them as much as we can. So yes, it is possible. There's also possibilities of that damage during the PGT A biopsy that could have affected the embryo a little bit to almost make it more at risk of that freezing and thawing process. So remember, when we are biopsying the blastocyst, we're removing cells from inside of it. We try to do that as delicately as possible to not cause damage to the embryo. And shortly after, we are then putting it through this flash freezing process, like Carolina said, in order to freeze it with vitrification. And essentially, we are then just plunging it into liquid nitrogen, which is minus 196 degrees. We can never really account for what happens kind of between those steps, as much as we are delicate and careful and follow our processes to a T. So yeah, I'm so sorry, and that sounds like a very hard thing to have happen. We do have another question that has come in here. Somebody who is considering PGTA in a country that is not PGTA, which might be someone from Sweden that's joined in, like where I started. Hi. Found PGTA only as a project since a few years. Okay, do you have any advice for me regarding what to ask the clinic to know if they are experienced enough, though they don't perform PGTA so often? One of the doctors is experienced in PGTA from another country since before. That is a very good question. Krisha, do you have any guidance on what a patient can ask their clinic to know more and understand how they're experts in this practice?
Well, obviously, no matter how many questions you can ask, no one can tell you the reply, but I will give you a few pointers that I think are important to know for PGTA better survival. We've seen over the years that we have much better survival when our timing is more precise. So, for example, it would be a good question to ask the laboratory, are they using time-lapse incubators to be able to pinpoint when to do the biopsy? Do they have a laser system? Because if they're not a PGTA country sort of doing a lot of PGTA, do they have a laser, or are they going to use old techniques in order to sort of make a hole in the zone of the embryo to get those embryos, those cells out? Do they have experienced laboratory staff to do it? For example, our lab may have 9 embryologists, but not all of those embryologists do PGTA testing. In order for us to allow them to do PGTA testing, they're the most experienced. They go through a lot of training. They do a hell of a lot of things before they're allowed to touch any of the embryos that are true PGTA cases, because you understand it's a huge risk. All of these questions have to be asked, but it's not just the laboratory part that they need to ask about. They need to know who's going to be the genetic laboratory that's going to be analyzing these cells. It's totally different to find a local clinic that doesn't have the experience to analyze embryos through NGS, as you said, next generation sequencing, or if they have a big provider that not only uses high-tech technology, NGS sequencers and things like that, but also sometimes AI technology also in combination to be able to get an even better result. So all of these things should be asked. And one final comment, I don't know what the lady is meaning by there's a doctor that's experienced. Is the doctor an embryologist or the doctor? Because the doctor, if we're talking about an infertility specialist, gets involved more in the consulting side of things, but not the actual biopsies, the actual processing. That's an embryology side of things.
Excellent, wonderful guidance. Thank you so much. And this is great because while we've been chatting, a lot more questions have come in. So I hope that answers your question there. Thank you so very much and keep them coming. So Carolina, for you, this question has just come in. If you or your partner have a known genetic disorder, is this something that the embryo can be tested for specifically?
Okay, so this is what I mentioned before about the PGTM, which is the pre-implantation genetic testing for monogenic diseases. So this kind of testing, correct me if I'm mistaken, but I think it probably changes from one country to another, but at least I'm gonna say what we do here. And if Chrysa, you have anything to add on, please feel free. But basically in Spain, yes, we can test embryo for specific diseases. So there are a group of diseases that can be tested without any consultation. The genetic laboratory will require a previous genetic report and probably new samples from you and your partner and maybe other members of the family to analyze very well where's the mutation in order to do a good study of your specific case and be able to approach the analysis on the embryos more specifically with the best technique. But there are also other group of diseases that require to go under approval from our Spanish committee. So normally the diseases that can be tested are diseases which appear early in the development and have high probabilities of being very very bad during the first years. And then other diseases which their development is lighter, then we have to ask this committee for approval. And only if they give us the approval, we can go ahead with the PGT. And this will take like 6 months, more or less, until we receive the result, if approval or not. So it takes some time.
That's excellent, thank you. And yeah, I think here in the UK, we've got a list of, I think, 1,500 conditions that have already been approved for to be able to test for. If there's something that isn't on that list, then you can apply for it to be tested for. Krisha, what's that like at NewLife?
Similar, but we apply for everything, so we need to get approval for everything. But if it's a condition like, for example, I don't know, sickle cell disease or cystic fibrosis, because there are no diseases that definitely need testing, we get the approvals faster. If it's something that isn't as known, the committee will ask us for more paperwork. So either a specialized geneticist will come in and sort of look at the case and say, what are the chances of a live birth? What are the chances of the baby, the child having an issue? And then they make a decision accordingly. But there are more specific cases than PGT A, as we were talking earlier. And all of those cases, at least in our laboratory, go through genetic counseling. So they need to speak to a counselor so they understand, is it really necessary? Is this going to solve their problem? Or is the chances of finding an abnormality 99%, and we're not going to find a healthy embryo? So there's lots of things that they need to speak about before we actually process it.
Brilliant. Thank you so much. Carolina, next question. This is about mosaic embryos, and we touched on this a little bit before, but somebody's asking here, what happens to the mosaic embryos? Should they be considered for transfer? If so, when and which ones? It's a good leading question there.
It's a good question, yes. So at least what we do, well, in Spain, we can transfer mosaic embryos. It is also something that the clinic decides, because you can decide whether the PGT laboratory reports the mosaicism or not. At least we do ask our laboratory of the PGT to report these results. And from the mosaic embryos, we have the possibility of transferring, but there are certain guidelines that only recommend a specific mosaic embryo. So the PGT IS and the COGIN established these recommendations for transferring mosaic embryos. They normally recommend, there are different types of mosaicism, so this is a huge topic. There are mosaic embryos. The classification is divided on how many chromosomes are involved, and if the whole chromosome is involved or just a part of the chromosome, and then the percentage of cells affected. So depending on that grading, it can be recommended. Mostly low simple mosaics, which are those mosaics with low number of cells affected, with the aneuploidy, and simple, which means that there are only 1 or 2 chromosomes involved in the mosaicism. But this transfer will always be done with previous genetic counseling from our laboratory. It's compulsory before considering any transfer. And then after the transfer, prenatal diagnosis is recommended. Amniocentesis, mostly, it's the biggest recommendation, but at least some prenatal diagnosis.
Totally in agreement.
Yeah. I think that's something that's quite important. I think patients do question that a lot, like why do I need those tests in pregnancy when you've already tested the embryo? But that, generally speaking, that is a recommendation for everyone, because we test the embryo at that time, and then it does continue to develop onwards, and we don't necessarily know what's happening after that transfer. Hopefully everything goes well and there is that healthy pregnancy that leads to a healthy baby. In some cases, we know unfortunately that's not the case, but being able to do those tests early can at least help manage that a little bit sooner and hopefully better emotionally. Yeah, thank you so much. Krisha, I've got a question for you here now. And this was in regards to something that we touched on previously. Someone's saying they're very curious about AI, and what can you say about an AI tool versus PGT A? And do you think that an AI tool can get a glimpse on the embryo's chromosomal abnormalities?
AI technology is being used everywhere. You know it. It's the future. It is coming into the genetic laboratories. One of the biggest genetics provider, Cooper Genomics, is utilizing it. They do have a platform that states that after starting using this platform, they were able to have more euploid embryos because they had a better detection of the quality and the quantity of the DNA that they were able to detect. Can I analyze this? I can't, I'll be honest. But I have to believe them because studies are backing this up. Is AI, though, do I believe that AI should be the only technology that we use? No, the human eye is never going to be bypassed. I think the embryologist's also point of view when they see an embryo in the lab should be a very valid point that people take into account, the clinicians, the patients. So even if we have, say, an embryo that comes out after genetic testing and after AI technology and after everything, and it says that it's euploid, but we have a very poor embryo morphologically, still we need to state this, still we need to be heard, because that embryo has less chances of surviving, less chances of implanting, less chances of developing into a live birth. So yes, AI can help, but to a point.
Exactly right. And I think something that's emerging a lot, with chat GPTs, etc., is that, these AI things are essentially they're trained, they're algorithms that have been built. We are training them to learn these things and to understand, but that's also based on our own knowledge of what we currently know and understand around embryo development. And that is also changing. So these models are growing, improving, but they still are not really, they're not quite there yet. I think we can get there. I think it would be amazing to have these AI tools that, like you mentioned previously, can detect these genetic and chromosome abnormalities without that invasive biopsy procedure, which is not quite there.
Not quite there, no.
But it might not be far off because it is going crazy fast, right?
Yeah.
That's an excellent question. Thank you so much. So we've got, I'm going to try to break this up a little bit. We've got a long question here. Thank you so much for submitting this. So there's someone who had a cycle 2 weeks ago. 11 eggs were fertilized and everything looked promising until day 3. After that, they only had a 5 BC blastocyst on day 6, which is currently under PGT A testing. So we don't know what the results of this yet. And this person is saying that, I know given my age, I'm 42, chances might be low. They do think that male factor is also involved. What is your advice? My partner smokes and is currently taking some medications. What else can we do? Carolina, what are your thoughts on this?
Well, I must say that there are different things to consider when looking at this specific case. Of course, the advanced maternal age is something that's gonna condition us very much on the genetic result. Unfortunately, the genetic content we know it's very much affected as the maternal age increases, and well, the embryonic arrest on day 3, it is true that is mainly associated with male factor, but it is also known that embryos do arrest in day 3 because of genetic abnormalities. There are huge chromosomal alterations that can lead to this arrest. Of course, if we want to optimize as much as possible, looking into the male factor is something very interesting as well. And given all this situation, I would maybe consider analyzing a bit more that factor, maybe analyzing fragmentation, for example. We do a lot of sperm DNA fragmentation at our clinic, where we analyze simple and double-stranded DNA. That we know that especially double-stranded DNA has a big role in embryo development, and that could be something to take into a consideration for future steps.
Absolutely. Thank you so much. Yeah, I think it is important to note that, you've got this early stage embryo development where essentially the egg is kind of responsible for those first couple of days. They are the powerhouse. They have all of that good mitochondria that helps with those early cell divisions, because it is a huge cell. They're all tiny, but huge in comparison with the sperm. And then at that day 3 shift, like Carolina said, there are big alterations once that kind of joint DNA takes over, and sometimes it can be related to male factor. Other times it can also be down to quality and maternal age. So there are lots of things that definitely could be looked at and reviewed. Obviously, fingers crossed for the embryo that is undergoing the testing, but should you need to go forward with another cycle, it's definitely warrants a review of these current factors, including the lifestyle factors, for your husband as well, because anything that you can do to optimize your fertility before that next cycle can really be beneficial once you do get started. Do you have any other thoughts on that, Krishna?
I do actually. What I want to point out is that sometimes embryo development could be considered a mini PGT A testing without the testing. And this is nature filtering out embryos. So even if we take an example of an egg donation case where eggs come from a 20-year-old woman, super tested, super woman, still, even if we get 10 eggs and 8 fertilized, it does not mean we're going to get 8 blastocysts. That isn't how nature works, even if we're using Superman sperm. Some embryos can't develop because simply they don't have the capability to develop into an embryo that can implant. So that should be always taken into account. Studies have shown in women of the age of 42 that we sometimes need up to 22 eggs to get one healthy embryo. So unfortunately, in these older maternal ages, we do need more eggs, more embryos to get to that healthy one. But it doesn't mean that we need to test for 22 embryos. It means sometimes that it takes us a hell of a lot of embryos to create that eggs, to create that embryo that will be healthy. But I wish you all the very best of luck, and I hope this one is the one.
Yeah, thank you so much. Yeah, it is just a little bit, difficult when we get these questions in. They're heartfelt and wonderful. Thank you so much. And we're limited because as embryologists, the first thing we want to do is to go and look at them. We want to see them under a microscope. We want to be able to provide a little bit more information than just the grade on paper. But yeah, fingers crossed for this one. So we do have a few minutes left if anybody has any additional questions for us tonight. This has been some wonderful discussions around PGT-A testing and PGT-M as well that came in there, and just lovely to hear, I guess, the different practices that well, I just got to thank you as well. But the different practices in different countries, and I think that's also something that's very helpful for us to learn and understand. And the two of you also see a fair amount of patients from abroad. I know, I can imagine. And just, I guess, a quick one on that. Would you say that they are a majority of your patients, Carolina? Do you feel that you have a lot of people coming from the UK, for example, to Clínica Tambre, where you're based?
Yes, actually, we have a big number of patients international wise, and they come actually from various parts of the world. So a lot of European countries with other legislations, as you say, also from the US, Australia. So we do see a lot of patients coming from abroad, from where legislation in their countries is more restrictive in these kind of procedures.
Definitely, I feel like that does happen quite a bit, where things might be a little bit more accessible and sometimes more affordable
Yeah,
in certain
that
countries,
as
and then
well. Yeah,
it becomes almost easier to book a flight to a different country and do it somewhere else
yeah,
than staying where you are, which is heartbreaking.
yeah.
But okay, so we did have a follow-up from the person who did just ask about what questions were best to ask your clinic, who doesn't have the most experience. Um, so just they're not sure of who's actually performing the biopsy for the PGTA, but the doctor is the professor, chief physician, professor in clinical genetics, and has many years experience. So yeah, I think now working as a consultant to undertake the genetic screening. So I think just again, much to that point is, just checking if that is the person who is going to be performing the actual biopsy in the laboratory, because most often the professors and the doctors are your treating, OBGYNs, for example. They might not be the ones that are trained in that biopsy procedure. So they could have worked in clinics that do these. They have experience in clinical genetics, which is great, and they might be able to provide that genetic counseling for you. They might not be the person performing the procedure in the laboratory. And one follow-up, not related to PGTA, someone is asking us, can an M1 egg develop into an M2 and fertilize, become a viable embryo, and then eventually euploid? Forgotten who to ask next. Krisha, do you want to start? I've lost track, sorry.
On the day of the egg collection, when we clean the eggs from the surrounding cells, we basically have 3 stages of maturity. These are called metaphase 2. They're completely mature eggs that we can go on and perform the ICSI procedure, and hopefully they'll fertilize. Metaphase 1 eggs that are an in-between stage of maturity, which if we culture in the lab, sometimes jump into maturity and we're able to work with them. And what we call GVs, germinal vesicles, that basically remain immature no matter how much we culture them, and we hope that they mature. Metaphase 1s, at least in our laboratories, are used if they go on to mature to metaphase 2. But we always warn patients that they do have smaller chances of fertilization, smaller chances of developing into a blastocyst. And unfortunately, I'm not sure if there's studies, but from personal experience, we do see that they have less chances of developing into euploid embryos. It's a similar concept, I'll put it this way, when we test embryos that are day 5 embryos, day 6 embryos, and I've even heard day 7 embryos being tested. Unfortunately, when we're testing embryos that don't meet the criteria that we want by the book, what it should happen by day 5, sometimes we see lower chances of having euploid embryos, yes.
Thank you so much. Carolina, do you have experience with M1s turning into M2s?
Yes, we do consider them for microinjection since we have to leave them some time. Meanwhile, after the decumulation procedure and the ICSI, we do look at them when we have to do the ICSI. It is true that I'm in the line with Chrysa that the chances that they end up forming a blastocyst are lower, well, the chances that they fertilize are lower and that they form a blastocyst are lower comparing with the metaphase 2. But of course, in order to increase the number of eggs we have, it's worth considering them and taking them into account.
Anything we can do to help maximize those chances.
Of course.
Well, thank you so much, everyone. We have cleared all of our questions tonight. Thank you, everyone, for joining. Thank you so much, Carolina and Krisha, for joining as well. I know it is late where you are, especially Krisha. You are still working in the laboratory. Bless you. I do appreciate all of the questions that came in too. Go ahead and keep an eye out on my IVF Answers website for more upcoming webinars, and hopefully see you all very soon. Thank you so much. This has been wonderful chatting. Thank you.
Thank you.
All right. Take care.
Likewise. Thank you. Take care.
Bye.